Good evening, everyone, and welcome to the Rutland Institute for Ethics TIDE Conference. I'm Dr. Tracy Fasolino, and I am hosting this particular session on the behalf of the College of Behavioral Health and Social Sciences. I'm super excited to have you joining today, and I cannot thank you enough for engaging in this conversation with us. We have an amazing speaker today, and I have the honor to meet her earlier this year. And I just was fascinated and overwhelmed by her passion for rural health and rural initiatives and equity. So I'm going to introduce you to Mrs. Sabrina Robinson. And I want you to basically let her take over and share some of her background because her story is absolutely phenomenal. For those of you who are joining us, you'll be able to type some questions into the chat. And as we come to the end, we'll be able to engage in some of the Q&A. So thank you so much for joining. And Mrs. Sabrina, I will turn it over to you.
Thank you so much, Dr. Fasolino, and hello, everyone. I'm going to go ahead and start my screen sharing. It is such a pleasure to be here. It is such a pleasure to talk about my passion on rural health. And before I do that, I do want to make sure that you know a little bit about me. So Sabrina Robinson, the Vice President of Operations of the Regional Medical Center in Orangeburg, South Carolina. I began my healthcare journey in the Bronx, New York, where my mother was the executive assistant to the CEO and president of 8 health centers in very, very urban Bronx, New York. And I thought I was not going to want to be in healthcare, and healthcare called me. I was an accountant by trade originally, and I do feel like healthcare, I was so passionate about it, so passionate about the patients, especially in the rural areas. And I'll get into my passion as it relates to urban versus rural a little later in the presentation. Spent 15 years in Florida, in the Central Florida area, and my passion for healthcare grew even more there, and that is where my rural health passion actually exploded. So without further ado, I would like to begin my presentation. My title is R.A.C.E, Rural Areas Conquering Equity. And this is going to be a looking glass into the social determinants of healthcare.
Sabrina, if you will, just drop down your display settings so that we're getting they're beautiful slides. Thank you.
You're welcome. Thank you. So I'm going to give you a little bit of an insight to Regional Medical Center. And if you have spent any time in South Carolina, you may know that Regional Medical Center is in very rural South Carolina. We are in Orangeburg County, and we service currently 4 counties, which is Orangeburg, Calhoun, Bamberg, and Barnwell. And at the Regional Medical Center, where I started in April of 2020, right in the beginning of COVID, the Regional Medical Center has a long-term history. We have been in business for 100+ years. We celebrated 100 years in 2019. And I always call TRMC the artery of the Low Country. Part of that is because we are smack in the middle of Charleston and Columbia. And we do feel like being the only rural hospital standing currently in the Low Country, that we service a large population, we service a large demographic. And as it states here, our mission is to deliver high quality, compassionate care to everyone we touch every day. Our vision is to provide nationally recognized healthcare. Even in little old Orangeburg, South Carolina, we are aiming to provide national recognition for healthcare to everyone with compassion, with quality, with service and efficiencies. Of course, our core values: serve the patient first. We are patient focused. We truly are. We have to share and inform and educate our population. We have to see, hear, and believe in each other, respond with your best, and reach beyond and pull together. And we consistently live that every day, all of the employees here at the Regional Medical Center. So the background of healthcare trends, and we're calling this the 7 C's. And I'm going to go over each C and focus a little bit more heavily on some that I feel are specific, even more specific to rural health. So of course, whenever we look at healthcare and we look at healthcare trends and healthcare reimbursements, we look at Medicare as our benchmark. There's a compression of margins within Medicare, and the margins have been decreasing since the early 2000s. We are expanding, the expense is growing, and it is outpacing our revenue growth. As many of you may know, contracting and patient volumes. So there's a significant shift to outpatient. R.A.C.E, focusing on reducing admissions, focusing on primary care, focusing on getting the patients out of the ED, and growth in high deductible plans. There's a change in delivery models. There's a disruption from new market entrants specializing in change to the care process, data support, and supporting healthy behavior. I'm sure many of you are tired, as we are in healthcare, tired of the pandemic and COVID-19. And I will tell you that during COVID-19, the change in delivery models was very significant. Significant from a telehealth space. So telehealth didn't just occur during the pandemic. Telehealth has always been here to some degree, especially over the last 5 to 7 years. But during the pandemic, we have seen an immediate shift to telehealth. Payers had to shift quickly. They had to pivot because the reimbursement model for telehealth was just not structured, not as a regular in-office visit. And so learning from that, during the last 2 years, we were able to understand that actually we can provide care. We can provide care from a telehealth perspective, even if it's different portions of care, even if you still have to go get your lab work and go get your modality with your x-ray and radiology, we still could manage you appropriately. Now that's a different discussion when we talk about comorbidities, and we'll talk about that a little bit later with regards to how many comorbidities that you may have. But changing delivery models is essential in healthcare. And I'll tell you, the healthcare industry is not very nimble. It is very hard for us to pivot. Consolidation. You see it everywhere. We've seen it more recently in South Carolina. Physician group consolidation, hospital consolidation, vertical consolidation, looking at different sources, looking at what's the center of excellence, looking at one brand, one name. As many of you know, the Regional Medical Center is county owned. We are not part of a system. And we would like to keep that as best we can from an autonomy perspective because of how much we feel we are important to our community. And that is the case with all rural hospitals. They are vital. They are essential to their communities. Consumerism. So with the start of high deductible plans, consumerism became more popular. And now patients are actually considered consumers. Patients can shop the market. There are different applications that are available to patients right now where you can see where your different costs are, because there are different costs depending upon the market, depending upon the area, depending upon the service. I will tell you that consumerism as it relates to rural health, the patients that are in the rural areas do not have as much luxury because they don't have a choice. TRMC, as an example, is the only hospital within 2,400 square miles. There are many patients that do not have a choice. We are it. They can't shop for healthcare. Where I come from in Florida, there were in Orlando, if you've been to Orlando, downtown Orlando, you have several systems and you are able to choose the different systems if you wanted to. I will also say that consumerism is probably more focused to the commercial patient, not necessarily the Medicare, not necessarily the Medicaid. And unfortunately with consumerism, and when you talk about free marketed healthcare, one of the things and the detriments with regards to that is that allows certain organizations to cherry pick. And we'll go over that a little bit later as well. Connectivity, personalized medicine, wearable devices, monitors, all of this takes connection. So what happens in a rural area that doesn't have broadband? What happens in a rural area that doesn't have strong internet? You might have decent internet, but you do not have strong internet. We have to look at that, and we have to look at what that trend is so that we can continue to help and provide access to those patients. And then, of course, competing on value. The payment models have shifted. We're going to talk about value-based purchasing and what that means. And I'll tell you, as long as I've been in healthcare, the payment models have shifted and tried to go from quality with HMOs to then production, quantity, and that's not the right answer either. So now we're going to a little bit of a hybrid with value-based purchasing and focusing on the value of the visit, focusing on the quality of care. So let's start with the basics. What is the definition of a rural area? And the most common definition is actually an area that's not urban. So when you look at that definition and you look at the map just of the United States of America, you see, okay, well, in New York City, anything that's not in the urban area is considered a rural area. A lot of people also, or in California, when you look at LA, when you look at Florida, Miami, Houston, Texas. But a lot of areas, when you look at the true definition of a rural area, even though that's the most common definition, you're looking at population density, geographical area, access and land use. From a more architectural standpoint, are there more farms? Again, relating to South Carolina. So in the county of Orangeburg, there's less than 100,000 people. There are some towns in Orangeburg that have 1,500 people, 700 people. And when you look at that in comparison to our landmass, that qualifies us as a rural area. A lot of people think about rural area, you see farms, you see a lot of grass, if a lot of agricultural areas and acreage. We have a freestanding ED, emergency room, that was in the Barnwell area, that's currently in the Barnwell area of the state. And I'll tell you that one of the reasons why we put that there is because one of the hospitals closed down there. And you will miss it if you are not careful, because you think you're in the middle of nowhere. And that's what many people think of when you think of a rural area. Of course, access is hard to come by, different types of access, resource allocations. I talked about connectivity. So all of that really truly defines a rural area. So this is a map from South Carolina DHEC of the rural areas in South Carolina. And I'm sure many of you can definitely relate to the fact that in the lower part of the state, you see the urban counties as Charleston and North Charleston and Somerville. You'll see rural areas, the big green dot right in the middle is Orangeburg. And then you see very rural areas. So Orangeburg is what I consider extremely rural. And then there's extremely very, very rural. And you'll be able to see that in the yellow. And actually the majority of the counties in South Carolina are rural. Now, this is RMC's service area defined. Orangeburg, as mentioned, is 2,400 square miles. And the primary service area for TRMC is Orangeburg and Calhoun counties, Bamberg and Barnwell. We have a combined service area that refers to both our primary and secondary combined services. For those of you who are very familiar with the state and the county, to our east, we have the Somerville, Charleston areas that we border. To our north, we have Columbia, and to our southwest, we have Aiken. Now, I would like to give you a critical thinking question. And we're going to have time at the end for questions and answers. And so feel free to answer these or expound upon them at the end of the presentation. And this really hits home for me because I was born and raised in the Bronx, New York, extremely urban. And now I live in South Carolina. And I lived in Florida in a very rural area as well, in Polk County, Florida, Dundee, Florida. And you might think, well, how did I assimilate? And I'll tell you that there are a lot of similarities, even though there's a lot of differences, but there are a lot of similarities with rural and urban areas. So what are the similarities and what are the differences? And I want you to take a minute and think about that. And they're not always as obvious as you think. The first is poverty. So in both rural and urban areas, the local government, the state government, and nationally, we're trying to overcome poverty. The living wage is not a living wage anymore. I'll paint a picture for you. In the United States, the salary per capita of a person is about $62,000 to $65,000 per capita. That's what they make. In South Carolina, it's about $46,000. And in Orangeburg, South Carolina, it's about $36,000. And of course, that's average. So you have people that are not even making a living wage. You have people making less than $36,000 annually that are raising children, that are raising their parents. And I'll tell you that in both rural and urban areas, that's the same. Infrastructure. So this is where you have opposite ends of the spectrum. In the urban areas, you have infrastructure where you can't keep up with because you have the population that is increasing. You're trying to fund it. If you're ever in an urban area, it seems like there's always some kind of construction going on with regards to the roads and trying to be ahead of the population expansion. And of course, in the rural areas, there's hardly any infrastructure sometimes. Sometimes there's dirt roads. Sometimes there are no stoplights. I remember when I first came down to the South, coming from New York City again, I didn't understand why it was so dark all the time. And it was because we did not have the things that I'm used to with many lights and such. And the infrastructure is key because when you look at the infrastructure in urban areas, it's still not keeping up with the times, and neither is it in the rural areas. Technology and communication. I cannot stress this enough with regards to communication, with regards to technology. Urban areas have a lot of communication access. They have broadband, they have better technology, and in rural areas, that's unfortunately not the case. Education. So again, these are similarities and differences. So you would automatically think that in an urban area, you have access to wonderful education, but it depends upon where you are in that urban area. So anywhere that is the underserved population, you will have not the best education. And that is almost always the case in the rural areas where you have to pay for education for your children or find a different school opportunity for your children. And that actually plays into healthcare, and I'll explain that a little later. Population, already discussed population density versus population shrinkage versus the globalization of population in both areas. And then of course, allocation of resources. So of course, when you talk about taxes and where they're allocated, how they're allocated, if you look at the poverty, you look at the dollar hourly wage, and then you see how much of that tax implication comes to be allocated to the different areas and industries, there's obviously a direct correlation. I would like to go ahead and transition to RHI. RHI is a wonderful source of information for rural areas, and bear with me as I pull it up. Rachel, do you see my RHI hub?
We see your slides right now.
There we go.
There we go.
Thank you. So what I like about RHI and the RHI Hub and the data visualizations is this interactive map. And if you have not been here and kind of dug into this data, I really recommend you do. I think that it's important for you to understand county-wide, statewide, and region-wide where all of the trends are. So we were just talking about some of the different indicators, and you can see poverty is up here on the selected indicator. So this is nationally, and you can just scroll over. It's very interactive. If you wanted to, you can click on the metro and non-metro. So look at the difference there. Non-metro and then metro, the metropolitan areas. That's a huge difference when you're considering all that is entailed with the non-metropolitan areas and the rural areas. If you scroll down, you can scroll down by state, and you can see South Carolina. And there's Orangeburg, 19.1% live in poverty. There's Calhoun County. Then you come up to Lexington. You see how it shifts and it changes. Very interactive, this map. Population. So we talked about population in one of the prior slides, and I think that this is important because when you're looking in rural areas, we're always trying to combat how do we increase, how do we get people to come here? A lot of people who live here are like, there's nothing to do in Orangeburg. Why would I live there? A lot of the young people that are here, they want to move away to Columbia, to Charleston, to Greenville, or even out of the state. And our goal is to keep everyone that needs to be here, that wants to be here, we want to keep them here. And we want to be able to attract different professions. We want to be able to attract doctors, and we want to be able to attract lawyers, and we want to be able to attract a different variety of industries into our state. Diagnosed diabetes prevalence is something that is near and dear to our heart here at TRMC. Diabetes runs rampant, unfortunately, here. And so this is another thing when you look at it in comparison to South Carolina, and then you look at it from a national level, and you'll be able to see, again, non-metro, metro, and all. So please, when you have an opportunity to learn more about rural health and why it is important to you, I recommend going on to RHI and the RHI Hub. It is very informational, and it will help you to understand why you need to know about rural health and why it matters to you, even if you're not working, living, or being a part of a rural health area. So let me get my phone. Okay. So what are the social determinants of health? Obviously, education, access and quality, healthcare and quality, the neighborhood, the social and community context, and the economic stability. And I will tell you that every time I do research on rural health, it makes me just even more passionate, because a lot of these things are taken for granted in some areas. And we have to fight for these things in the rural areas. We have to be a voice to our patients that don't have economic stability, that don't have access to education, that don't have access to quality healthcare, a neighborhood, social and community context. All of these are the social determinants of health. And we'll go over that as to why in a little bit. So here are some external environments and conditions that contribute to our health or lack of health. Of course, age, sex, and hereditary factors play a role. Your lifestyle plays a role, but your work environment play a role, the general socioeconomic, cultural, environmental conditions, unemployment, living and working conditions, the services, housing, all of these play a role. And some of these items are out of your control. When you talk about breaking generational curses, generational healthcare concerns and looking at these living and working conditions, looking at these lifestyles. It starts at a young age if we're going to try to break the generational gap. So this is a surprising statistic that many of you may not know. And working in the healthcare field, I do see it every day in the rural communities. Social determinants of health. According to the World Health Organization, social determinants of health account for X% of health outcomes. Now I want you all to pause and I want you to think about what that percentage might be. It is commonplace for you to think that how much can a social determinant of health really account for your health outcomes? Maybe it's 10%, maybe it's 20%. It's 80%. 80% of social determinants of health are accounted for health outcomes. That means, and only 10% are related to medical factors. That means poverty and education and all of those factors that we just talked about account for 80% of the health outcomes. It's not necessarily what you don't do with regards to eating. It is, but it's not, because when we talk about eating and eating the right things, do you have enough money to put food on your plate? Are you educated enough to understand what that difference is? But when you look at this, that means that a lot of our health outcomes could be preventable. So this is near and dear to my heart, preventative health. The reason why this is near and dear to my heart is because we need to focus on wellness versus sickness. And that starts at a young age. We all, if you have children, we all ensure that all of our children, from the very, very beginning, from the time that they're born, we're conditioned to take them to regular checkups. We're conditioned to say, you got to go to the 6-week checkup, and then the 6-month checkup, and then the 1 year. And then all of a sudden, when you transition from pediatric care to adult care, it kind of just falls off. There's no true transition. And what we do in healthcare, unfortunately, is we treat sickness and don't focus enough on wellness. And I'll tell you, from a reimbursement perspective, payers, Medicare, Medicaid, commercial insurances, they really want you to focus on wellness. They want you to focus on getting your physical. If you have commercial insurance, even if you have Medicaid, usually your annual wellness visit is free or low cost. Now, I will say this. We are designed as a people to focus on Medicare. Medicare is the benchmark. We have taxes that come out of our paycheck that go to Medicare. We have focus on age 65. And the reason why, to me, that is a problem is because when you get to age 65, it's too late. It's too late. And that's where you're focusing on sickness versus wellness. We have to focus on preventative health. Now, there are levels of prevention. Primary prevention is avoidance, immunizations. For those of you who have been got their COVID vaccine and their boosters, prevention of disease, that includes mental health. How are you preventing that? Then there's secondary, there's early detection. There's mammograms and screenings, colorectal screenings, and different things that you can do for secondary prevention. Then there's tertiary prevention. And that's the reduction of disability and prompt rehabilitation for management of existing conditions. So as you see these tiers, if you are in your 20s, you need to focus on primary prevention. You need to focus on avoidance. You need to focus on prevention of disease or injury. Now, if you don't focus on that, that's when you move to secondary prevention, and these can be done in parallel. I am not being all inclusive. I know that we can have different ailments at different ages, of course, but I will tell you that again, the vast majority is preventable. And you do not want to get to the point where you're at end stage renal failure and you're trying to figure out what to do to now live. We need to focus on the prevention part, the avoidance part. So that's where health equity comes in. I'm going to read this directly off the screen. This is the best definition of health equity, the attainment of the highest level of health possible for all people. We should all be able to achieve health equity. It requires valuing everyone with focus on ongoing social efforts to address avoidable inequalities, historical and contemporary injustices, and elimination of health disparities and healthcare disparities. What's the inverse of that? The health inequality. What is the differences? We talked about the social determinants of health a little bit earlier, but we need to talk about the health inequities that are avoidable and unjust. This is caused by systemic differences in social conditions. Again, many times this is not at the decision of the patient. It is just based on the environment that they're in, and therefore these are actionable. Where are our healthcare inequities? Comorbidities, access, healthcare awareness, the mortality rates, lifestyle, mental health, which we're going to go into, and telehealth. When you look at, as an example, Orangeburg, one of the startling statistics that I was first introduced when I came here was that Orangeburg has the highest prostate cancer per capita in the state. Orangeburg. Diabetes is rampant. Obesity is rampant. And by the time the patient comes to the ED, many times it is too late. And that's when we look at our mortality rates. Our focus with regards to healthcare awareness. We have to educate. We have to educate our populations in the rural areas. Now, I keep focusing on Orangeburg because I want to tell you it's any city USA. These healthcare inequities are any city USA. Now, from an ethnicity standpoint, I will tell you that part of the reason why patients wait is because they feel that they're not safe. Can they trust their provider? The healthcare in minority communities, I'm going to tell you an RMC personal experience. There are patients here that have come to me and said, I do not trust that provider because that provider does not look like me, which goes to recruitment. Are we recruiting the type of provider that can relate to our patients? We all know about the Tuskegee experiment. And I will tell you, when we were going through COVID, and we were trying to convince our patients, our doctors were trying to convince our patients to get the vaccine. All they kept talking about was, nope, I remember or I heard of the Tuskegee experiment. Clinical research currently is not representative of minorities, and more research does need to be done in order to help this level of the population. Generational changes. Another personal example is I come from a family that does not eat vegetables. They don't. They will not eat vegetables, and they were obese, and they had high cholesterol, and they had diabetes, uncontrollable diabetes. And my daughter, who is now a second generation American, she's a vegan. She made that change. She made that shift. And that's a little extreme, but I will tell you that she saw that there are generational changes that needed to take place in order for her to be healthy. A lot of our patients are asking, do I feel safe? When is there going to be another pandemic? What are the COVID impacts? I talked about the recruitment of providers and the latest technology, appropriate access, and every day you hear of another rural hospital closing. I do want to hover around latest technology because I'll tell you that many of the rural hospitals, TRMC included, we try to tend to focus on the latest technology because we feel as though if our urban counterparts and our suburban counterparts and our metropolitan areas can afford or provide the latest and greatest for their patients, we should be able to too. At Regional Medical Center, we have 2 robots that we have purchased for surgery. We have the orthopedic Mako, we have the Da Vinci, and there are some times where when you look at that, that actually brings a sign of relief to the patient saying, well, we have the latest technology and that kind of correlates with quality. Why does all of this matter to me? What if you are going to school in Clemson and you're not from South Carolina? What if you have no intention on living in a rural area? It still matters to you. I talked about the Regional Medical Center earlier being the artery of the Low Country. We are a trauma level 3. If we did not exist, our counterparts to our east, west, north, and south will have a significant burden managing all of these patients here. I'll also tell you that healthcare costs are astronomical. And when I remember the first time that I actually visited the State House here and the State House in Tallahassee, Florida. And it was healthcare day. And I went up there thinking, why does this matter to healthcare? Why am I here? And that's when I realized that in the state of Florida, greater than 50% of their budget was focused on healthcare, greater than 50%. Well, what happens to infrastructure? And what happens to education? And what happens to everything else? So healthcare is 50%, and then everything else gets 50%. That's why it matters. That's why it matters to everyone. So here's another critical thinking question. Has the increase in cost of healthcare in the United States resulted in better outcomes? You would think that cost correlates with outcomes, positive outcomes. US spends 19% of their GDP on healthcare. In 1960, the spend was 5%. We went from 5% in 1960 to 19%. And unfortunately, the increase in spend has not improved outcomes. How do we track that? We look at mortality rates. Of course, the mortality rates are a little skewed over the last 2 years because we've had a lot of deaths related to COVID. But I will tell you that despite all of the deaths related to COVID, the #1 killer is still heart disease. And what do you have to do to try to prevent heart disease? By the time you have been diagnosed with heart disease, it's going to involve medication therapy. It's going to involve other things, procedures potentially. When you hear that you have to exercise 350 minutes a week, that's for your heart. That's not for necessarily losing weight. That is actually for your heart. And unfortunately, the additional spend has not improved our outcomes, not everywhere. And that's where we talk about the overall cost of healthcare. We talk about consumerism a little bit earlier. Well, a lot of that is related to the fact that costs have been pushed to patient responsibility. High deductible plans came into effect, and now sometimes they're just astronomical, they're $10,000 before you can get even a touch of healthcare. And for those of you who don't know, healthcare is the only industry that does not set their rates. We cannot set our rates. The government sets our rates. And the only difference in what we get paid is where we are, our payer mix. Do we have high government payer do we have higher commercial payer? Commercial, of course, are the Blues, the United Healthcares, the Cignas, and we can have the exact same volume as our counterparts that have higher commercial rates. The exact same. It could be 100 people versus 100 people. And if we have 100% of our payer mix as a government payer, whether it be Medicare or Medicaid, versus somebody else who has 100% commercial payer, their margins could be double. And that is the difference. And that is the cost of healthcare. Again, that's why it matters to you. Patient responsibility. What do you pay for your copay? Why? Are you focusing on your health? If you focus on your wellness right now, and you take advantage of the fact that you have a free wellness package in your insurance plan, you don't have to worry about that cost later on. So we talked about the social determinants of healthcare. Bringing it home with regards to the social determinants of mental health. Behavioral health equity is just as important as overall health equity. Behavioral inequity is more prevalent in the underserved communities and among our youth. So when we talk about our youth and we talk about trying to change generational behaviors and generational trends, behavioral inequity is more prevalent and it has to have more focus. According to the National Alliance on Mental Illness, 20% of youth aged 13 to 18 live with a mental health condition, whether it be anxiety or depression. 37% of students with a mental health condition, age 14 and over, drop out of high school. 70% of youth in state and local juvenile justice systems suffer from a mental illness. Now, those are staggering numbers. So when you look at mental health and physical health, what came first? What's a priority? Should you focus on your physical health so that your mental health can be good? Should you focus on your mental health so that your physical health can be good? I'll tell you, being in healthcare, we see a lot of physical health ailments that come from mental health ailments. Meaning, I can have anxiety, stress-induced diabetes, stress-induced cardiac arrhythmia. So if you don't focus on your mental health, your physical health could be manifested in negative ways, in negative outcomes. So I really don't want to lose the point that it really is the whole person. It's the whole person. It is your physical health, your mental health. You cannot choose one or the other. So my last critical thinking question of my session, what else could we invest in if we controlled healthcare costs and focused on wellness? What can we do with regards to focusing on rural health so that it's less burdensome, so that our population in the rural areas can have more access, so that they can be more educated? Could you imagine if we had the same type of education as our urban areas? Focus on true wellness. What could we invest in? Everything comes full circle. We talked a little bit about value-based care, but it's really about what is our risk stratification, what is our risk engagement, what's our transformation management or data exchange. There's a reason why we're focusing on value-based care. There's a reason why we have to shift away from production and quantity. We have to ensure that we are focusing on all areas of healthcare and not just leaving out one part or the other. That's why my passion is so strong for rural health. So that concludes my presentation. And this is my contact information. We're going to start the Q&A session. And I really hope that this information allowed you to think critically about the rural areas and the social determinants to healthcare as it relates to rural areas.
My gosh, thank you so much, Sabrina. That was fantastic. And I'm sure if we were in a classroom or in a conference room, there would be this standing ovation right now because you spoke so passionately about rural inequalities and rural health. So thank you very, very much. And as the members, the attendees start thinking about conversations, I'm going to pose one to you. Actually, I want to just share something with you that the College of Behavioral Health and Social Sciences dean and a lot of the departments are really focusing on food insecurities. And when I think about the rural inequality and access to these vegetables, like you said, your daughter is a vegan and she's, she has access to some of that. It's really a challenge for some of our rural communities. They end up going to the Family Dollar or the Dollar General, and a lot of times you don't really have the types of foods that we're asking them to do. I'm a nurse practitioner, that. So I'm asking them, okay, now cut out your salt and cut out, your high fat foods. And yet what we have available is not fresh fruits and vegetables there at Family Dollar. It is more the canned foods, the canned vegetables. And so I would love for you to just maybe speak to that for a second, having the experiences that you have down there in Orangeburg.
Sure. So you're exactly right. Food insecurities is a problem, and food and how you intake your nutrients obviously will be a catalyst to how your health is, what your outcomes are. And I will tell you that we have to bring the education to the patient instead of waiting for the patient to come to us. So we have to be more instrumental with regards to having food pantries. And we partnered here with the Tri-County Health Network, and they have boxes. They have, every so often they'll have just boxes of fruits and vegetables and grains, and that's so important. And I'll tell you, initially there wasn't really a lot of it wasn't really popular, and then it started to get popular, and then to accompany that, teaching them how to make it, because a lot of people see a head of lettuce and they're like, I don't want to eat that. I don't want to just eat that. And it's about being creative. And so I think that it is our obligation to continue those, and not just have them once a month, have them once a week, have a cooking class. And that way they're not going to the Dollar General and they're not eating off the dollar menu from McDonald's, that they're able to make better choices because it'll impact them. If you look at, I'll tell you some examples that I've had with young kids. And we always say, or we have said in some of our training, if you can have $5 now or $5 later, do you want $5 now or $5 later? And of course, they always say $5 now. So if you can focus on your health now versus focusing on your health later, you get the $5 now. And so sometimes, it takes a minute for them to think about that, but it's about teaching them and bringing it to them more often and not just occasionally. And I think that we just need to make sure we do a better job and bring that information and the actual food to the patients in their communities.
Absolutely. I think you're right on tap with that. And then up here in the upstate, we have some of the same issues with food insecurities and access. So thank you for providing that oversight. And our little chat sessions has started incoming questions. So let me just cue this up for you. What are some specific reasons for rural inequalities?
So I will tell you that sometimes it's just, it is the people thinking that they cannot make a difference for themselves, honestly. I will tell you, we have an inpatient rehab area, floor unit, and we have more amputations that I would care to even describe. And when you go around and you talk to these people and you say, what happened? What happened? What could you have done differently? And they'll tell you, my mom was a diabetic, my grandma was a diabetic, I just knew I was going to be a diabetic, and I knew I was going to get an amputation. So I will tell you that I really feel like that it's mindset. It really is mindset, and it's changing the mindset. It's also no different than the mindset of, I'm going to be in a gang. If you're in a gang area, I'm going to be in a gang. My brother was in a gang. My sister was in a gang. My daddy was in a gang. It's about saying that I can get out of this. And I think that that's part of the difference in rural areas, is it's more compounded there.
That makes sense. I was kind of thinking too that a lot of times when I'm in these different groups of people, they don't really understand some of the inequalities that are in the rural community. So in a lot of ways, like you are today, Sabrina, and I know some of these future leaders that are on this call are going to be that voice that brings awareness to more of the national platforms or even the state levels about the rural inequalities. And as a matter of fact, one of the students said, what are some ways that students can do? What can they do to help with rural health? And I'd love to hear your insight on that.
I would say come visit us. I would say come and visit us, because that's a way you can help. Because understanding when you see it versus when you just hear about it makes a difference. And that's one way you can come and get educated on some of these social determinants. And I'll tell you, in Orangeburg, I live in West Columbia. Well, someone might say, well, why you're so passionate about rural health? Why aren't you living in Orangeburg? I have a 12-year-old son, and he'll be 13 soon. He's in 7th grade. And unfortunately, the education system here is not the best. And some may say, well, that's hypocritical. Well, I want to still get into that school and educate those little young minds. Because I'll tell you, once you get the elementary school student to hold their parent accountable, that's when change happens.
I think we're going to have to look at that younger generation to continue carrying the torch too. And you spoke about, literacy, and we talked about health literacy, that whole level of reading literacy. If you're not comfortable reading a recipe on how to make food that is healthy, or understand some of the discharge instructions that we give, and I'm not sure how many of our attendees are actually in the healthcare particularly, but just that those two coupled will play a huge factor in compliance when it comes to following their, this is not the preventive that we really want to get to, is it, Sabrina? But it is the reality of where we're at right now. And how can we address some of those things by just screening for health literacy and reading literacy? Because if we're not real sure, then we're going to miss out on that opportunity to do that education. It looks like we have another question too. What are possible solutions to improving these inequalities, and also what can individuals do to make a difference? I'll let you take the lead on that one again.
Sure. So I really think that one of the things that we can do really is truly, I'm going to go out on a little silo here. I think we should talk to our legislators a little bit more. You are all constituents in your areas. And I think sometimes there are blinders on again, why it's important to everybody else. And it goes back to, let's not just focus on what we have right here. And I think that sometimes you only focus on that, and that's what the squeaky wheel does, right? If your legislators hear the squeaky wheel about, fill in the blank, that's what they're going to focus on. But I think that if you as a constituent say, what can we do to help our rural counterpart? Because the reality is, these are counties that neighbor your counties. It's the county right next door. And so I think I'm going to go out on a limb and say, talk to your legislators and find out where they stand on this, and find out what else they can do to help cross the border.
I love that. And, for those students who might be on that are nursing students, the 2020 publication about the future of nursing has a whole section there on our involvement with policy. And I believe that's what Sabrina is really focusing on too, is, bringing that awareness of health needs through a nurse's lens, or even beyond that, through a healthcare provider's lens, and connecting with the legislators, because they are actually the ones that drive the money, right? They drive the resources. And when you talk about the rural health or even the rural communities, where's the infrastructure, right? Where does that get fit into? So excellent thoughts. Is there any other questions that students or participants? Oops, I think I just have one. Let me see here. You touched on an experience where a minority patient did not have trust in their provider because they looked different, weren't of minority status. From my understanding, your solution was to hire more minority providers, hire one person over the other based solely on race, rather than build trust between the two. Would your solution be the same if the race were of the two people were switched? For example, a white person that didn't trust a minority provider?
So that's an excellent question. And I'm sorry that you took from that my only solution was to hire somebody that looked like them. Absolutely, we have to build the trust between all providers. I will tell you that I had to have some hard questions because it just wasn't race influence, it was gender influence as well. So if you're a female and you prefer a woman OBGYN, would you be okay with just having a male OBGYN? And if you're steadfast on I am not okay with that, then I as a recruiter have to look at that. At the end of the day, we have to educate the patients to say that this person we selected is the best for this community, and they work to the top of their license. And so I've done both. I feel as though we need to have a diverse medical staff. We have to have men and women. We have to have Black and white. We have to have Spanish and Indian. We have to have young and old. And so I did mention that one patient that I spoke about, and I said, oh, you're right. We actually don't have enough diversity because we did not have enough diversity from a racial perspective. But you're absolutely right. That also involves us educating the patient on, we are recruiting the best for you, whether that is Black or white or male. And sometimes that's not going to be enough. And that's why you have diversity in your medical staff. So you can say, well, if this is what you want, we have it. But we were at the point that we didn't even have that. And so, unfortunately, what we had was a lot of male Caucasians. And so that did not sit well with some of the younger females. It did not sit well with some of the minority females. But you're exactly right. It shouldn't be one or the other. And so I apologize if that's how it came across, but we definitely address all when we recruit. Great question.
Yeah, that was a great question. And just kind of building on that, it's about trust, right? It's about trust with your primary care provider. It's about trust with the medical community. And, I know you all down there at RMC are working very hard at containing, establishing and reestablishing and supporting that trusting relationship so that the patients down there really do feel like you are, you're doing everything you can. And I did have an opportunity to come visit you, and I was just so happy to see such wonderful people, right? Just walk in the door. They're so friendly, and the actual technology that you have there to offer to your patients is really to be applauded. And the idea that you are still, you are, a solo, if you will, rural medical center, right? You are standing on your own 2 feet is another amazing feat by your team there at RMC. So again, my kudos to all of you down there.
Thank you. Thank you.
If we don't have any more questions, I think we're coming up close to the end of our time. And whoops, wait, hold on. Choosing to hire someone based on race is racist. Prove me wrong. That is the comment from, or I guess a question.
No, absolutely. I think that choosing to hire someone based on race, I wouldn't call it racist, but I don't think that we should choose to hire somebody based on any one thing at all. That's not, it's just not appropriate. I think that what I'm just expressing how our patients feel and their fear. The patients, that's how they feel. That's how they didn't want to take the COVID vaccine. They're like, well, I want to hear from somebody who might would look like me. But again, it's not just a race thing or a gender thing. We should not just be focusing on one or the other. We have to have our best foot in front of us. And I think that it's important to make sure that we have a diverse medical staff.
Very good. Thank you, Sabrina. Appreciate that. Again, I don't see any current questions pending. So I will, thank you very much, Sabrina, for your time, your amazing talents, your presentation. We're really highly regard what you all are doing down there. We appreciate Rutland Institute for Ethics sponsoring this presentation for our faculty, our students, and do know that this will be available via recording, and I guess in about a week. And I would imagine there'll be a lot of folks watching this again, Sabrina. So I really appreciate your time.
Absolutely. And I would love to continue the dialogue about recruitment efforts. My contact information is here. Open to having further conversations. And this was just an honor and a pleasure. And I really appreciate you inviting me to do this.
Well, we'll see you again soon, I suspect.
Yes, yes.
Thank you, guys. Appreciate you all joining us today. Have a good evening.
Thank you.
Bye-bye.